and there is no defect in their speech-producing apparatus. The main defect is hearing loss. Period from birth to 5 years is critical for developing speech and language. Early rehabilitation or rehabilitation after identification and assessment is vital. Before 6 months of age, if hearing loss was observed and managed, then higher vocabulary scores and better expressive and comprehensive language skills would be there. Factors are inner ear abnormalities, which can be genetic or non-genetic causes. Anomalies can affect the inner ear alone, which can be non-syndromic, or it may form part of a syndrome which is syndromic. Anomalies affecting the inner ear may involve only the membranous labyrinth, or both the membranous and bony labyrinth, non-syndromic trait. And secondly, we also have Alexander dysplasia, only affects the basal turn of the cochlea, only high frequencies are affected. Residual hearing is present in low frequencies and it can be exploited with hearing aids. Okay, then we have mitral aplasia, which means that there is complete absence of membranous and bony labyrinth. Even the petrous apex is absent, no cochlear implants or hearing aids can be used. External and middle ears may be completely unaffected. In Mondini dysplasia, only the basal coil is present, or cochlea is only 1.5 turns, however there is incomplete partition between the scali due to the absence of osseous spiral lamina. Conditions may be unilateral or bilateral, it may be seen and we'll learn about later. Or there could be enlarged vestibular aqueduct. So in here, the vestibular aqueduct will be enlarged more than 2 mm. Endolymphatic sac is also enlarged and may be seen on T2 MRI. Early onset of sensory neural hearing loss would be there, which is progressive. Vertigo may be present and perilymphatic fistula may occur. Now let's talk about semicircular canal malformations. So both the superior and lateral, or only the lateral malformations may be seen. They can be identified on imaging technique. Maternal factors include infections during pregnancy, drugs during pregnancy, radiation. So drugs during pregnancy can also be toxic, which are chloroquine, which cross the placental barrier and damage the cochlea, and thalidomide affects the ears, and it can also cause limb abnormalities of heart, face, lip, and palate. We call as Waardenburg syndrome. So it is going to be manifested in the form of heterochromia iridis, which means that both eyes would be of different color, and there would be white forelocks in the baby, and it could also manifest with vitiligo and dystopia canthorum, which means that the distance between the medial part of the eyes would be very much, and unilateral or bilateral sensory neural hearing loss or can be caused. It can be congenital and it is autosomal dominant. So the next syndrome is called Usher syndrome. So it causes night blindness, retinitis pigmentosa, and sensory neural hearing loss, and it causes delayed hearing loss, and it is autosomal recessive. Now let's talk about something which has a lot of effect on the heart, so which is the Jervell-Lange-Nielsen syndrome. It manifests with a long QT interval. It causes fainting and deafness, and it is congenital and it is autosomal recessive. It causes syncope and sensory neural hearing loss. Now for the Pendred syndrome, it causes non-toxic goiter, usually evident before puberty, and perchlorate discharge test shows defect in organic binding of iodine. It is congenital recessive and it causes sensory neural hearing loss. Treacher-Collins syndrome, Apert syndrome, or which causes syndactyly, and Cruzon syndrome. So for the Treacher-Collins syndrome, remember that all three of these are autosomal dominant. Treacher-Collins syndrome, there's going to be lower lid coloboma, mandibular hypoplasia, malar hypoplasia, and conductive hearing loss, and antimongoloid palpebral fissures, and the pinna is going to have microtia, and there's going to be atresia of the meatus, and the malleus and incus will be malformed, but there will be no abnormality to the stapes, which would be normal. Now for the Apert syndrome, remember syndactyly, so it also causes conductive hearing loss by stapes fixation, and it also has a Cruzon-like face. So for the Cruzon-like face, remember frog eyes manifest in the form of exophthalmos and consequent and convergent squint, and it is also going to cause hypertelorism, parrot beak nose, mandibular prognathism, premature closure of the cranial sutures with mental retardation. So with C, you have to remember Cruzon and frog eye, as well as cranial sutures premature closure. Now for and it is going to cause what? Conductive hearing loss. Now for the Alport syndrome, just remember CH, which is corneal dystrophy and hereditary glomerulonephritis. It is going to cause progressive sensory neural hearing loss, autosomal dominant or X-linked, and delayed hearing loss. Now for the short neck plus vertebral fusion, just remember Klippel-Feil syndrome. It causes sensory neural or mixed hearing loss. It is autosomal recessive. However, all of these were autosomal dominant. Okay, and it is also congenital, and it is not delayed like this one. And it causes short neck, low hairline, limited neck movement, as spina bifida, as well as ear canal atresia. Also, Treacher-Collins and Cruzon will cause conductive hearing loss and congenital as well. Now for the BOR syndrome, or the brachio-otorenal syndrome, and it causes conductive or mixed hearing loss. It is congenital and it is autosomal recessive. Now for the Wilder-Bank syndrome, so it is going to, when you remember Wilder-Bank, just remember Klippel-Feil plus sensory neural hearing loss and sixth nerve palsy, which is the abducens nerve, and it is congenital and X-linked. Now for the Stickler syndrome, it is going to have Stickler, which will be autosomal dominant, and it causes conductive or sensory neural hearing loss, and it is delayed. Now for the Van der Heef syndrome, just remember that it causes blue sclera, going to have a delayed onset. It can be all of them, like it can cause conductive hearing loss, mixed or sensory neural hearing loss, and it is delayed, and autosomal dominance. Now for the Pierre-Robin sequence, now for the Goldenhar syndrome, or OAV syndrome, or oculo-auriculovertebral syndrome, or facio-auriculovertebral dysplasia. So it is going to have facial asymmetry, equibulbar dermoids, and preauricular tags or pates, and upper lid coloboma, and low set ears, and ear canal atresia. It is also going to have cardiac abnormalities, preauricular tags or pits, hemivertebrae in the cervical region, and it is autosomal dominant. It causes mixed or conductive hearing loss. Or it could also be sporadic extrachromosomal multiple, which is trisomy 21. It causes microcephaly, mental retardation, or now let's talk about the perinatal causes which happen during birth or in the early neonatal period. So it can be in the form of anoxia, which causes damage to the cochlear nuclei and causes ear hemorrhage, and it also causes placenta previa, prolonged labor, cord around the neck, prolapse cord will cause fetal anoxia, and premature baby and LBW baby, or birth injuries, which means that baby was born through a forceps delivery, which caused intracranial hemorrhage with extravasation of blood into the neonatal jaundice, which means that the bilirubin was less than 20 milligram percentage the inner ear, or neonatal meningitis and sepsis, or increased time spent in the neonatal ICU, or due to ototoxic drugs used for neonatal meningitis, septicemia. Now for the postnatal causes, so they can be genetic or non-genetic, but manifest later in life, and deafness may occur alone in FPSND, which is familial progressive sensorineural deafness, or in association with certain syndromes like Alport syndrome and Klippel-Feil-Hurler and Hurler syndrome. Non-genetic causes essentially are same as in adults, and they are due to viral infections, serous secretory otitis media, ototoxic drugs, so viral infections, and trauma, for example, fracture of the temporal bone, or middle ear surgery, or perilymph leak, or it could be due to noise-induced deafness. So when there is suspicion of hearing loss, so the child sleeps in noisy environment undisturbed, and the child is unstartled to loud noises, and the child fails to speak at 1 to 2 years. Now for the partially hearing children, they may have defective speech and they may perform poorly in school and be labeled as mentally retarded, or all children at risk have to be screened and followed. So what are the risk factors for hearing loss in children, which was proposed by the Joint Committee on Infant Hearing Loss, on infant hearing, updated to 1994. Number 1 is family history of hearing loss. Number 2 is Torch's infection, which happens prenatally. Number 3 is craniofacial abnormalities to the pinna or ear canal. Number 4 is LBD and hyperbilirubinemia requiring exchange transfusion, and ototoxic medications including but not or 0 to 6 at 5 minutes. So basically we mechanical ventilation for 5 days or longer. Another one is stigmata or other findings associated with a syndrome known to cause sensorineural and or conductive hearing loss. So what are the screening procedures? Number 1 is testing hearing in high-risk infants, and they are based on infants' behavioral response to sound signal. 95% of children with one or more risk factors have normal hearing. 50% of children with sensorineural hearing loss had no risk factor. Program for universal neonatal screening for early detection was made, and there are 2 important tests. Number 1 is OAE, and number 2 is ABR. So otoacoustic emissions are generated at the outer hair cells. They can be picked up from the external ear as the energy is produced by them. It travels in reverse direction from outer hair cells towards the ossicles, and then towards the tympanic membrane, and then towards the ear canal where it is picked up. And OAEs or otoacoustic emissions are absent if the outer hair cells in the cochlea are non-functional. There is middle ear effusion, M, or canal debris mechanism, which may persist for 3 to 4 days, and otoacoustic emissions are normal even when 8th nerve is non-functional, which is the vestibulocochlear nerve. OAEs can be used in 8th nerve neuropathy diagnosis, and ABR are generated in response to stimulus of sound presented to the ear and picked up from scalp. With a response of 30 to 35 decibels, normalized hearing level, infant who passes this test has normal hearing. Infant who fails this test, repeat the tests. Now for the arousal test. So a high-frequency narrowband noise is presented to infant for 2 seconds when he is in light. A normal hearing infant can be aroused 2 times when 3 such stimuli are presented to him. Now for the auditory response cradle. So screening device for newborns. A baby is placed in a cradle, and his behavior, which are trunk and limb movements, head jerk, and respiration, in response to auditory stimulus, is monitored by transducers. It can screen babies with moderate wear or profound hearing loss. Number 1, we have neonatal screening procedures, which include ABRs, OAEs. Then we have arousal test, and we have ARC, which is auditory response cradle. Number 2, we have behavior observation audiometry, which includes Moro's reflex, craniopalpebral reflex, CP reflex, and cessation reflex, which we're going to discuss about later. And we also have distraction techniques for children who are of 6 to 18 months, and we have conditioning techniques for children who are of 7 months to 2 years, which include VRA, PA, and visual reinforcement audiometry and play audiometry, which is for 2 to 5 years. And then we have objective tests, OAEs, ABRs, and impedance audiometry. Now for the behavior observation audiometry. So auditory signals are presented to an infant. It produces a change in behavior, for example, alerting cessation of an activity, widening of eyes, or facial grimacing. Then we have Moro's reflex. So we are going to observe sudden limb movement and head extension in response to 80 to 90 decibels. And then there is the CP reflex or cochleopalpebral reflex. So child responds by blink to a loud sound. With the cessation reflex, infant stops activity or starts crying in response to a sound of 90 decibels. The distraction techniques, they are for children of 6 to 7 months. So child turns his head to look for the source of sound. So in this activity, we are going to take child in mother's lap and can see rattle sound of 8 kilohertz, or they could be low frequency hum or whispered sound as SSS, or xylophone sound, or warble tone or narrow band noise of 500 to 4000 hertz. Next we have conditioning techniques. So this includes visual reinforcement audiometry. Child is trained to look for an auditory stimulus by turning his head, and behavior is reinforced by a flashing light or an animated toy. It helps to determine the hearing threshold using standard audiometric techniques. This is appropriate for children who are of 6 months to 2 years. Next we have play audiometry. Child is conditioned to perform some activity like play techniques. This is appropriate for 2 to 4 or 5 years children. Next we have speech audiometry. So child is asked to repeat names of certain objects or point them out on the pictures, and voice can be gradually lowered, and hearing level speech discrimination is tested, and expressive ability of child is examined, like the child would have to name toys. Okay, now for the objective tests.